So we're just going to be talking to the College of Radiologists, the Australian New Zealand College of Radiology. And we've got very fortunate to have three significant people to join us. Jennifer Cowie, who's the Network Director of Training in South Australia, and Tan Duong, who is a recently qualified fellow and who worked at Royal Darwin Hospital, and Brian Baker, who's a current trainee, who's still going through training, but who graduated from the NT medical program. So that's a wonderful mix that Jennifer's put together for us, really. So I'm very happy about that. I'd like to acknowledge country that we're all on, and that varies a little bit today. I'm in Larrakia country, Sherry's down there with Aranda Mob, and I think the rest of you are in Ghana country down in Adelaide, South Australia. So I'd like to pay our respects to the elders from those regions, as well as any of you who are joining us with Aboriginal descent. So I'm kind of very happy to be hearing from this group of people as well, of experts about this area of training. I'm the medical director of the Central Training Hub, and I work Congress. I'm a GP, and I guess with our interest in ultrasound and things, we're getting a little bit more into your territory probably for the first time, although we do have a number of our trainees who learn to do x-rays and things as well out in remote settings. So we probably have more to do with you in terms of directly than some of the other specialties. So we've got the Royal Australian New Zealand College of Radiologists, and we're going to start with Jennifer, who's been in this game, and she's actually worked in Darwin as well, she tells me, back in 2010-11.
Yep, that's right.
Thank you, Jennifer. Would you like to start the ball rolling, just telling us, I think, about training in general?
Yep, absolutely.
How your college works. So if we can get you to share your screen. Mm-hmm. Here it comes. Thank you very much.
No worries. So hello, everybody. My name's Jennifer Cowie. I'm the Network Training Director in South Australia. I'm going to talk to you a little bit about radiology training in South Australia. It's a very popular program, but by no means one that is absolutely impossible to get into. Just to give you a little bit of a background, radiology training in South Australia gets around about 60 to 80 applicants every year. That's for an approximate 6 to 10 new registrar positions. So we're about to actually do some interviews now. So the application comes out in April, and then the interviews we get are in around about June. It's actually at the end of this week for the August intake and for the February intake of next year. So we interview approximately about 3 times as many positions as we need. So you can see that it culls from 80 through to about 20 to 30 interviews, and then around about 6 to 10 get a spot. There is occasionally a second intake at the end of the year, but that's unusual. At any one time, we'll have around about 50 registrars rotating through South Australia, and that's 20 at the main hospitals of Royal Adelaide and Flinders, and then 6 at QE, 4 at Women's and Kids, 1.5 at Lyell. We used to have a rotation up in Darwin for 2 registrars, and that was an amazing rotation that I did as well. But we don't currently have it. We are very interested in getting it back up and running, but we have a few logistical issues there. So your pathway through training, most colleges have a part 1 and a part 2. Radiology is no different. The part 1s in radiology, however, are immediate within their first year. So, for example, you may well get in February, and then your part 1s will be in March. So this is an anatomy and a physics paper. It used to be 4, but there's only going to be 2 papers next year because there's a new curriculum coming in 2022. So it's one of those things that if you're interested in radiology, as part of the recruitment process, you need to show that you are ready for the part 1 exams. You're not allowed to sit them until you're in a training program, but essentially as soon as you get into the training program, you're straight on, essentially. We try to help out the first years because obviously it's a big jump between knowing how to do your RMO job exceptionally well and being so integral to the member of the team to then coming onto radiology where you may not actually, have read terribly many chest x-rays or CTs before in your life. And we don't want to pretend that you can suddenly do this job. So you're very, very protected. So there's no on-call, no weekends, no nights for the first 6 months of your training. And then there's also a really extensive education program. So every lunchtime, you are meant to get protected teaching, and vast majority of the time it actually happens, as opposed to people who say that there is some teaching and then it doesn't happen. So you get your lunch break between 12:30 and 2, and that's so that you've got that hour lunch break between 1 and 2 to be able to have the tute. Now, South Australia is slightly different in case you also hear from other training sites throughout Australia for radiology. You rotate through most of the hospitals through your 5 years here. I think it's really excellent because it gives you that quaternary hospital stuff at the Royal Adelaide and at Flinders, but then it also gives you the really specialised stuff at the Women's and Children's Hospital. A lot of people don't get that when they're isolated interstate, for example. So South Australia's got one up on that just because of the way in which our program is structured. The specialty rotations are to the Women's and Children's Hospital in the third year. And because of the actual level of support needed for your Part 2 examinations in your fourth year, you're almost always at one of the two major hospitals at Flinders or the Royal Adelaide. The Part 2s, as you'll see, are 10 exams, 3 writtens and 7 vivas, or in all of the body systems. It is a tough specialty in terms of its exams. It's not insurmountable. First time passes through the Part 1s will be approximately 70 to 80%, so it's not like it's a disastrous time. First time Part 2 getting through all 10 exams is around about 15%. You do have 4 shots to get all 10 exams, but it is one of those ones where most trainees, I always tell the good trainees, you are definitely going to get 7, 8, 9 or 10. You're going to aim for 10. And if you don't, we're going to help you clean up the rest afterwards, because that's what sometimes will happen. But as I say, you are supported through the whole thing. So some commonly asked questions in radiology. One, will I be in a dark room for the rest of my life? No, you won't. You have a significant amount of both clinician input, so you're talking to every single team, as well as patient input, particularly when you get out and in private. I spend half of my day with patients with your musculoskeletal issues. So that is, something where people think you're going to be squirreled away in a dark room. Yes, we do work in a dark room. I love my very dark curtains, but it's one of those things where it's important to know that there is still contact. The second question I get a lot is, what if I just want to do interventional radiology? I would suggest if interventional radiology is the only thing you want to do, then radiology may not be for you. Interventional radiologists are extremely important, but they only take up about 15 to 20% of our workforce. And the vast majority of the time is your core stock standard radiology. So by all means, if you're absolutely certain and you don't mind 5 years of 90% normal radiology and 10% interventional radiology, then by all means, smash through the training program. But I would suggest to you that you need to also find a love for radiology full stop and not just the needlework. Third question, do you subspecialise like the USA? No, we don't. Australia is one of those places where we all have to be generalists, and then we have a subspecialty interest after that. So unlike the USA where they subspecialise really, really early and then just do like knees for the rest of their career, Australia doesn't have that. I much prefer being a generalist with a subspecialty interest. It means that I don't go stark raving mad looking at the same thing over and over again. Number 4, what if I want to do radiation oncology? I included this question because I get this question a lot. Even though we are part of the same college, it is a very different training program, and I can't tell you anything about it because I don't know it. But there definitely are radiation oncologists who will be happy to talk to you. And then how hard is it to pass the Part 1s and Part 2s? I've already kind of mentioned that it is tough, but not insurmountable. But yes, you do need to work hard. So radiology is really for anatomy and pathology nerds. That's how I came to it. Also, it's for those people who are happy to be part of the team and finding out what's wrong with the patient, but not the primary carer. If you really, really love being the primary decision maker and the carer, radiology is possibly not for you. For those whom ward work is not their thing, I very happily say that I've worked at Flinders for over 10 years and have absolutely no idea where the wards are. And then for those people who know how to work very hard, you do have to be able to talk to every multidisciplinary team meeting at the same level as all of them. So you'll do the ENT meeting in the morning and you'll be talking about the ENT things, and then you'll do the liver meeting in the afternoon, and you really do have to talk about the liver things, and in between you're doing chest x-rays. So it is a high level, but so long as you can prioritise your busy work schedule, you'll be totally fine. And then those who want to experience an expanding field of expertise, radiology really is for you. It's changing significantly in the last even 20 years. Every few years, a new MRI sequence will come out. And every time we're showing that we can find different things and find it better and find it easier. And then also working in a high demand area, demand for radiologists is so high that there is currently no delay in consultant job vacancy. There's a little bit of delay possibly in public just because their level of jobs are not as high and as fast to overturn as the private sector, but the private sector has certainly got plenty of jobs available for radiologists now. So that is possibly an extremely stark contrast to our radiation oncologist friends. But radiology essentially is expanding so much because it's around about approximately 8% increase in scans performed per year, but we are certainly not increasing our workforce by 8% per year. So for more information, every TMO unit should be sent a candidate's guide, and if you don't have one, you can ask them for it. That just essentially gives you information about how to get into radiology training in South Australia. Feel free to email, and then also talk to the radiology colleagues or the registrars here today. We've got both Tan and Brian online just to kind of chat through early training and late training. But for now, thank you very much, and I'll hand back over to Sam.
So that was very succinct and helpful presentation, I think, for people seeking this career. We're going to move to Dr. Duong, Tan, and he's going to explain to us, I guess, a little bit more about what it's like going through that process, having done it very recently and is now a consultant. So we'll get to you. I think we're okay for you to share your screen, aren't we?
Okay.
Thank you.
Hello, everyone. My name's Tan. So just a little bit of background about myself. I studied at UWA, and one of my goals on my bucket list was to try and catch a barramundi, and that's how I ended up in Darwin. That was my attempt. I never ended up getting there, and in terms of catching that barramundi, I caught a barracuda. So anyways, I worked up
3 years.
Yeah, that's right.
That's sad.
It was, despite many fishing charters, I was never a great fisherman. So I was an RMO and sort of quasi-registrar during my time in 2011 to 2014. I was only going to stay on for a year, but then I met my now wife, who was from Adelaide, and that's how I've ended up in Adelaide. So whilst I was, so I spent a few years up there, really enjoyed it. And one day a friend of mine rang me up who was just starting radiology, and he said, Tan, I just got into radiology, really enjoy it. You should give it a go. And so that's how I came about to apply for the SA radiology training program. And so, yeah, I was a trainee in SA through the SA network there, and we were lucky enough to still have that 6 month secondment to return to Royal Darwin Hospital as a radiology trainee, which was phenomenal. And I finished in January this year. And I've started working with Benson's, and I'll also start working at one of the smaller hospitals, the REPAP hospital, in the coming month. So this kind of was tying in with what I'm presuming Brian will talk about with regards to the sort of part 1 exam. So I'll focus on the later phase of the training. So as Jen was mentioning also in the previous, in her talk, you've got the part 1 exams. So you've finished those. Now what's next? So you're on that road to becoming that little bit more independent. You're starting that on-call shift, and you're working towards building that knowledge database of cases, and you're starting to work after hours as well. And you're also starting to think about the next hurdle. And the major one is the part 2 exams. It is hard. It's balancing full-time work and also trying to study at the same time, which can be quite an arduous task, but it is where you have to balance both of them, and you're balancing it at the same time as sort of you're attending the shoots, whether they be at lunchtime or they could be at after hours, particularly as you get closer to your examinations. And there's great support here in terms of the consultants, irrespective of whichever hospital that you're based at or rotating through. They're always willing to help you in giving shoots, whether they be during work hours, or sometimes it can be after hours as well, as you get closer to the exams. And as I mentioned, there's involvement of the after hours once you've completed your past part 1 exams. But again, that's very well supported, and you have really good feedback as well in terms of when you do the work after hours. You can get addendums, or you just get feedback from the consultants that are checking your work the next day, or evening, or during that shift that you're on. So once you've done your examination, your part 2 exams, which, as Jen mentioned, they've got the 10 major components there, which is a big hurdle. You've got just a few more things in terms of experiential requirements. One of them is a part 2 project, which involves having to it could be published in a journal, or you could present it at a conference, such as the ASM. For example, this year it will be in Melbourne. Hopefully that sort of progresses in our sort of post-COVID world, having more face-to-face sort of conferences. So that's one thing. And once you've done that, that you've completed your formal training bit. And upon reflection, yes, it is a very challenging journey, but what lies ahead is a very rewarding career. Again, as Jen mentioned, definitely radiology, once you're finished, you're in a very fortunate and lucky position with regards to employment opportunities. If you're not ready for employment there, you can still pursue fellowship options. Obviously, that's slightly limited now with lack of overseas travel, but once that opens up again, that would be incredible. You can still do fellowships within Australia, so that shouldn't limit you. Whichever subspecialty that you would like to do your fellowship in, it's so diverse. It can be things like interventional or even artificial intelligence. These days, it's forever, as Jen was alluding to before, just constantly improving our accuracy, our precision in diagnosis. Also, radiology is very unique in the sense that it's so adaptable to this changing environment, particularly in this post-pandemic world, where you have the flexibility of being able to work in like teleradiology. So you don't have to leave the house if that is your preference for whatever reason. And this ties into the fact that it allows you flexible work hours. And then that, as we sort of always hear about, a better work-life balance as well. And that's something that I've found definitely has been certainly the case with radiology since finishing. This was a slide just to touch on the fact that from a perspective of someone in NT, it is quite tricky to sort of pursue or see what you're getting yourself into or in for if you're based in the NT, particularly more so with that lack of the registrar rotation that's going through the NT, which hopefully will resume in the near future. But when I was trying to decided to apply for radiology, it was the registrars and the consultants that were there at Royal Darwin Hospital, the people that you always were going down to ask your requests or imaging requests. I found that invaluable, asking them experience or just getting their opinion, what their thoughts of radiology training were like. And I think that's something that would be slightly difficult in, for example, the NT hospitals, whether it be Royal Darwin or Alice Springs. I think Jen mentioned this before, that potential fear of lacking or missing out on patient interaction. I don't think that's the case at all. You definitely, working in private practice, you see patients every single day, and you're doing injections or procedures. It's a great balance, not just sitting in front of a computer. It's definitely a lovely balance between patient interaction and also going back and looking at the images. You're sort of problem solving. It's a lovely balance. The challenges, people say, oh, radiology is very hard. It can be very difficult due to the exams. I think that's not unique to radiology. I think any subspecialty, you're going to have to jump through the hurdles, and unfortunately examinations are one of the key metrics of that occurring. So it's not unique to that at all. On the flip side, my experience in Darwin, I felt that the fact that it was such a friendly hospital and such a great atmosphere, it gave you a better appreciation of cultural diversity and puts you in good stead when you're in a training program, whether it be South Australia or anywhere else in Australia. And as you're well aware, there's a lot of pathologies that are unique to the top end, particularly, for example, during the wet season, melioidosis. A lot of people haven't heard of that down here. So it's just helps you think outside the box. And again, as you go through radiology, it just helps sort of build that differential diagnosis. So I wish you all the best. It is an amazing career, and all the best with if you're interested at all applying. And if there's anything that you're sort of interested in or worried about who to contact, the directors of training at the respective hospitals here in SA are super friendly and more than willing to help and answer any questions that you may have. Similarly, ask your colleagues, your friends at Royal Darwin Hospital, radiology department at Alice Springs Hospital. Ask the radiologists that come up there from Jones. They're incredibly friendly and would be more than willing to answer any questions. Thank you.
It's a really lovely, generous view of working up here, which is nice that it affected you like that. I think it is an extraordinary place. Okay, so we're going to move on to Brian, who's graduated here in the Northern Territory, and tell us about the early part of training. Brian, getting that going.
Thank you, everybody, for attending today. My name's Brian. This is a picture of a building that you guys may recognise, anybody who's worked up in the top end, on a lovely monsoonal morning, just as it was my last day actually at the RDH. I am a second year trainee currently. Can you please go next slide, Abdul? And just to prove I've got a little bit of street cred, I've got some pictures up there. So I was an undergraduate in medical radiations at UniSA, and I went up to work as a radiographer, or actually a nuke med tech, up in the Royal Darwin Hospital for a few years before going to Flinders NT. So I was a NT graduate. We used to affectionately call ourselves funts, but I'm not sure that that's necessarily what we should do. I spent 4 years after graduating at the Royal Darwin. I was an intern and a resident, and I spent a couple of years as an unaccredited surgical registrar. And from early 2020, I moved back to Adelaide as a radiology trainee. So it looks like I'm one up on Tarn. There's a picture of myself with a barramundi over on the right-hand side. And here's a picture of myself in the bottom.
Is it legal? Is it legal?
Very much so, Sam, very much so. Picture of myself in the bottom left with a couple of familiar faces for anybody who has worked around Darwin for a little while. There's a psych reg and a rehab reg that now still work up there that were co-graduates of mine at the NTMP. And in the bottom right is myself as a surgical registrar trying to grow a very bad moustache from Movember. If we could please have the next slide. Now, I know some of this has already been covered very well by Jen and Tan with thanks, but a little bit of why I chose to go into radiology. Obviously, I had a background in it. I do enjoy anatomy, and hence I gravitated towards radiology with the background and anatomy. I also find radiology actually has a good balance of anatomy and procedures, and also medicine as well. And I think it piques your interest when you're in Darwin. Good medicine and interesting medicine piques your interest because we used to see so much stuff up there that we haven't seen or haven't really seen and dealt with down in Adelaide as much. Things to consider have already been very much covered, but it is a different work style with no clinics and no ward rounds. You don't have the ownership of the patient care as such, but to say that you don't have patient contact would be misguided, I think, because quite often when you're doing any procedures or even talking to patients, sometimes even within our ultrasounds, when we go in to view our ultrasounds in real time, we talk to patients and interact with them. It is a little bit difficult with radiology. You really have to know that that's the direction you want to go, because unlike general medicine or general surgery, you can't really try before you buy. My recommendation would be to ask a current trainee and just have a good read up of the information that's available about things. Most of our trainees aren't only radiology. It's worth saying that many of the trainees that we've got at the moment, many of the people I work with were BPTs or had done some unaccredited surgical registrar work. Some of them came straight into radiology, but I think that having a little bit of extra background is actually beneficial when it comes to actually reading the scans. And I know that seems unusual, but you actually can start to think like a physician or think like a surgeon when you're reading the scans, and it actually makes things a little bit easier. And obviously within radiology, you can find a little bit of an individual niche. As Jen said, we don't specialize straight out, but towards the end, some people will go towards a special interest, or once they become a consultant, they will go into a special interest area and pursue that, whilst also being a general radiologist. Next slide, please, Abdul. Next slide, Abdul, please. Excellent. So first year, it's the basics of radiology, really. It's usually at Flinders or RA/QEH. The RA and the QEH kind of share people a little bit. So, and that was where I started. At the QEH, I can only speak from my personal experience, but I was actually supernumerary for 6 months, which meant that I really got to have no pressure introduction into radiology. Didn't have any after hours for the first 6 months, and it just gave me a chance to learn the basics of X-ray, CT, and ultrasound. And for me, even coming from that background, it was a real steep learning curve. Getting your head around three-dimensional anatomy can be quite a steep learning curve as well. And doing some basic procedures within first year as well. So the big aim of the game in first year is to pass those first exams. It was 4, it's now 2, but it's 2 longer ones rather than 4 shorter ones. So it's about the same anyway, from a point of view of somebody coming into the program. But the assessment is on physics and anatomy. Physics is, we have tutorials and some training on that, and it can be difficult if new. If you're considering looking into radiology, I know there are some preliminary physics courses about. I think University of Sydney might offer one. Anatomy is on your own study, and it can be very difficult. The curriculum is changing. One thing I will say about anatomy is it doesn't change. So you can plug along with anatomy learning as in other areas, and it's applicable to radiology. The anatomy examination is probably equivocal to the GSE. It's not a bad thing. I did it before getting on to radiology. It's not a bad thing to do that beforehand if you're interested, because it's intense anatomy learning, and when you study in radiology, it's intense anatomy learning. So those sorts of things can really be beneficial to you. If anybody's looked into it before, a lot of people talk about the 4 shots at the exams, and you get March and September of years 1 and 2 to try and get through these exams. But at the end of the day, most people get through them fairly early on. Next page, please. Year 2, you do some smaller assessment and research projects that we build on your techniques a little bit. You do on-call and after hours more, night shifts sometimes. Attendance in clinical meetings becomes more of a part of your day-to-day work. I find this particular part of the work actually is really good for learning, the attendance in clinical meetings. It can be quite intimidating at times, but it does actually help just build your knowledge. And you just have to do the work and to get confident in that particular, to get more confident in your radiology. So you do move around sites. So I have been here for 18 months, and I have been to the three different hospitals that I mentioned earlier. If you haven't completed your part 1s by the second year, you've ongoing study for your part 1 exams in early second year.
Wonderful. So we've got a pretty good picture of where and how you go about this. I just wanted to ask Brian first, and I guess we've got Brian and Tan, both were in Darwin and thinking about what to do, and then went to Adelaide. From your points of view and from Jennifer's point of view, I guess, are you at any disadvantage working in Darwin until you start your training? Is it easier if you get in the know with people down in Adelaide? What's your feeling about that? It's something that worries young doctors here.
I think from my point of view, from a point of view of medicine, I think that you set yourself up very, very well from being in Darwin. I think that the way we used to see medicine up there and the way we used to have to be fairly independent up there was something that has carried over. I mean, in Darwin, you couldn't strictly just be a surgical registrar. You had to know how to manage diabetes, and you had to know how to manage heart failure. And you couldn't be a medical registrar because you had to know about surgical conditions, whereas things tend to be a bit more compartmentalized down here. Yep. If you're going before your training, I think getting those formative years behind you is probably, there's probably not many other places where you can really, I used to joke about saying you can really do first world medicine with third world disease at times. And I think Darwin is advantageous in that. I can see the argument of not being known to the system. Jen will have to talk about that a little bit more. I was at a bit of an advantage because I knew people in radiology when I was up there, but there are also 2 other people who weren't radiographers beforehand that have since got onto radiology training. One of them is the second year. So I think that the idea that you can't do it without, knowing the right people is probably not as important as the medicine that you get from being up in Darwin.
Should take Jennifer next, just your view, Jennifer?
Sure. It's a really interesting question, and I think it's an important one to kind of discuss. What I will say from a recruitment point of view, I talked about the 60 to 80 applicants. We have applicants from all across Australia, and South Australia, Northern Territory, we know that that's our main pool of people. So we're always going to look slightly closer at South Australian and Northern Territory trainees. And really, from a recruitment point of view, it certainly does not disadvantage you to being from Darwin. But just like every other trainee trying to get an interview spot, the key things, which are fairly self-explanatory really, is what the panel is looking for is that they are looking for people who have got an interest in radiology and so therefore have already been preparing for the Part 1 exams that I talked about before, who are relatively academic and possibly published, who have really demonstrated a really breadth of experience, because as you would imagine with the multidisciplinary meetings, you have to have a breadth of knowledge in radiology. And so it is of absolute benefit to you to have a breadth of experience before you get into radiology, to be able to help you better understand what those groups want. So they're the kind of big three things I think that the recruitment team is looking for in terms of their radiologists. And certainly if you have a Darwin background, it does not disadvantage at all, because I think anybody, and a lot of us on the panel have been to Darwin, realise that the breadth of medicine is prominent in Darwin, and so you will have that extra level of experience that, say, an intern in RMO1 may not have got in a bigger city environment, for example.
Okay, well, and maybe just quickly, Tan, how did it work for you? You had somebody who encouraged you, but
yeah. So Sam, yeah, I actually didn't know anyone here in SA. It was only through the registrars that were rotating up there, and they spoke very highly of the SA program. But yeah, when I flew down for the interview, I actually didn't even know where Flinders Hospital was, and I got there an hour early because I thought it was so far away. So yeah, it was so it definitely doesn't, and I agree with what Brian's saying, that that sort of compartmentalization, the lack thereof up in Royal Darwin Hospital, because you get to rotate through so many different specialties, and that breadth of knowledge is actually an advantage when you apply for a program such as radiology in SA, because you do see a lot more pathologies and you experience a lot more in your early years before compared to, I reckon, a lot more of the junior doctors in the SA network, for example. So, yeah, I think it's an advantage.
Thank you. Just to Jennifer, just about, I don't think we have any resident radiologists at the moment in the Northern Territory, which seems rather extraordinary. But is that the way things are going? I know that people are reporting from overseas. There's a lot more sort of remote radiology, I think, going on now than in the past. Is that the future?
Hopefully not. I think there has to be a balance between the registrar work force and the training aspects thereof, and also the absolute volume of work that has to be done in radiology.
I was talking post-grad, sorry.
So yeah, post-grad, yeah. Right, I understand.
Yeah.
I mean, I think I suppose there's a couple of things to do with that. One is there's a significant number of studies that you need to actually perform on site, not only just for Medicare billing requirements like musculoskeletal injections and things, where they won't pay you unless you actually have a radiologist on site, but also for literal being able to talk to the patient and say, where is actually the pain and what is going on and where is the tingling going and all that kind of stuff. So there is a certain subset of radiology that's never ever going to be able to be shipped overseas, and some significant governmental restrictions in terms of RANSCA certification, in terms of being able, you can't just build a large building somewhere overseas and ship all of your studies over there. That just actually won't fly with the government, because there's some fairly stringent regulations as to what you're allowed to report when you are physically overseas and what you aren't. So I don't see that happening in the near future in terms of the amount of things changing. Certainly, there is advantage made of teleradiologists, particularly in the overnight setting in Australia, in private, so that you've got support from someone who's actually awake somewhere else in the world, looking at the scan rather than you crawling out of bed at 2 a.m.
Yeah.
And so long as they're, RANSCIV certified radiologists, then I think that that's a bonus, because we can then also do that inversely for the overseas country as well.
Yeah. Okay. So that's sort of, I guess, because we have visiting radiologists, as it were, coming and spending the week here doing those procedures, I guess you're talking about. And what size town could somebody, is everybody all radiologists going to live in the capital cities, or does Cairns have radiologists? Does Townsville?
Yes, all really. Even small towns have radiology departments. Whether or not they are attached to a larger radiology department or a private radiology firm would be another thing. So, for example, Cairns Hospital, from memory, is actually serviced by a South Australian radiology firm. And so there's either the option of living in Cairns and working in Cairns for that radiology firm, or commuting backwards and forwards from South Australia for that.
On what sort of cycle? I'm just thinking of the lifestyle for people like that.
It's very variable. So I don't work for that particular company. But my understanding is that it's extremely variable. You can actually say, yes, I would love to do X number of months, or this week here or that week there, or it doesn't suit my family to travel, so I won't be doing that.
Yeah.
I currently at the moment have a rotation to Mount Gambier, which is twice a year. I fly up to Mount Gambier for a week. It's fantastic. I love it. I've taken my children there. They think the house there is amazing.
I'm from Narracourt, so
very nice. Yeah. They went to the caves. Very important. But it's one of those things where, depending on what you want to do once you're out, your flexibility is fairly high. You can actually say, I would like to go over here or go over there or do this. Certainly, if you're with a group of people, then you're always going to be balancing it with what other people want as well, just like any other workplace. But there's a fairly good amount of flexibility there if you wanted it.
Thank you. I guess I just wanted to ask a bit about, we've got a bit about rural. So we've asked about Darwin, haven't we? Does the college, apart from the experience of somewhere like Darwin, is there any, pressure, or does the college trying to improve access in regional centres and things? I know all colleges are under a bit of pressure from government for this sort of thing. I just wondered how that plays out. So if someone's from a rural background, very committed to offering services in a rural area, how would you see that helping them or whatever? And what sort of job would they be looking for, I guess?
It helps them in radiology because there is a encouragement from the college to make sure we have good representation of people from rural areas, and we get audited and accredited with regards to that as well. In addition, the South Australian training program will get audited and accredited with regards to the rural access that the trainees have during their training time, and that's something that's strongly encouraged from the college, to have a rural rotation. Since we lost Darwin about 6 months ago, we are looking for alternative options. As you would be aware, it's tricky to have the private public kind of conglomeration that's required for a rural rotation, because most of the time rural centres are housed by the more private radiology firms. which is the same in Darwin or Alice Springs or Gambier or somewhere like that.
Yeah.
So I would say it's definitely on the radar. It's something that we are looking forward to increasing in future. But it is sad that we don't have it currently for our trainees. But from a RMO trying to get into radiology kind of perspective, it's an encouragement and a thing from the college that is very looked favourably upon to have rural trainees.
Yeah, great. Thank you. Well, that's good news. Thank you very much. We'll probably wrap up now if that's okay. We really appreciate your contribution. We will edit this slightly, probably as a thing, because I was muted for a start half the time. I apologise for that. We've got some just links there. We're happy. I think we're going to give some contact details, certainly for us. You've given us some contacts, and I think all of you have been willing to be available to have a chat with people. And particularly encourage, I guess, people thinking of this career to talk about how you get ready. You've said about getting ready, and we've talked a little bit about physics and anatomy, and that's probably, it sounds like that's how you're going to demonstrate you're ready. Is that fair, Jennifer? Just in that before your part ones?
That's fair. And also, breadth of knowledge and trying to see as much radiology as possible, that kind of thing.
Yep. No, that's great. Okay. So we'll hope that you get some more recruits from the NT. It sounds like you're doing quite well, actually, from what Brian's told me. So it's wonderful.
We are.
Keep up the good work. Thank you very much.
No worries. Thanks for today. See you later.
Thank you. Thanks.
Bye all.
Thank you.
Thanks very
Thanks,
much.
Tan and Brian.
Brian.
Thanks, everyone.